Everybody. I know people will be joining as we go along. I'm Lisa Barrow, and I'm very happy to welcome you to this seminar on behalf of the Rocky Mountain U.S. Cochrane Network affiliate in Colorado, as well as the Colorado Evidence Synthesis Program. So this is one of our joint seminars, and we are absolutely delighted today to welcome Professor Lisa Askie, who's at WHO in Geneva, and Lisa's title there is Scientist and Methods Lead within the Quality Norms and Standards Department. And I think you'll learn all about what that actually is during Lisa's talk. And I have known Lisa for a long time as one of the methodologists I've always looked to when I have sort of any questions about systematic reviews and evidence synthesis. Lisa has been involved in Cochrane for many years. She was formerly at the University of Sydney and ran the clinical trials registry there, has been very involved in kind of innovative types of evidence synthesis like that involving individual patient data. And about a year ago, Lisa moved to this position at WHO because WHO is really expanding in their methods related to evidence synthesis. And like me, when I moved to Colorado a year ago, Lisa didn't quite expect to be working from her home office all of that time, but as you'll see from her talk, a lot is happening at WHO. And just as an aside, it's really hard to get snowshoes in Geneva, and Lisa is on the lookout for some that are made here in Colorado. So if anybody has some insights for her, she wants to hear them after the talk. So her more complete biography is there. We can put questions in the chat. We'll have time at the end for questions, and this is being recorded. So over to you, Lisa. Thank you so much for joining us today.
Thank you, Lisa. My pleasure to be here, even though in this strange virtual world, but very, very happy to be here. And thanks for the introduction. I will talk a little bit more about my role in a moment. Just to first say that, sorry, now I've got to advance the slide this way, that I am still with the agreement of WHO, still part of Cochrane, in that I am still one of the co-conveners of Cochrane's Prospective Meta-Analysis Methods Group and a member of the Cochrane Individual Participant Data Methods Group. But just to also point out that the views expressed in this presentation are my own and don't obviously necessarily reflect the views of the World Health Organization, although I don't think I was going to say anything particularly controversial. What we're going to just walk through in this session is a bit of my background, so you know where I'm coming from, the quality, what the quality norms and standards are at WHO, and some of the innovations that has brought, and then particularly how COVID-19 has impacted on some of the ways we synthesize and use evidence at WHO, and finish with a couple of other initiatives that are coming soon and leave some time for questions. So my background is I was actually a clinical nurse and midwife for many years. This is an old picture, but did things mostly in pediatrics, midwifery, and some time in Malaysia. And then a while later, did a Master's of Public Health and got into Cochrane reviews, particularly in neonatal pregnancy and childbirth, was a trial coordinator, and then moved and did a postdoctoral fellowship in Oxford. Some familiar faces there for those of you who know the Oxford team. And as Lisa said, managed the Australian New Zealand Clinical Trials Registry, and worked in academia and had a systematic review health technology assessment team. Did most of that from this lovely part of the world, a nice body of water, Sydney Harbour. And then moved, as Lisa said, a year ago to this body of water, a nice, beautiful Lake Geneva, to work at WHO as an international civil servant. That's the first time I've taken that role. I did manage to get in the building on the first day or two, and did actually get allocated quite a nice office that does look over this nice jet. But most of the time since then, I have spent, like many people, working from home. And so that's mostly what I've seen, the building, the outside of it, since I've been here in Geneva. So WHO, we core business really is producing guidance for health. And we produce a lot of guidance about lots of things. This is just a smattering of course, the many different things that range from quite specific intervention type questions about different types of treatments to things about general other public health things such as housing, etc., etc. So a very wide variety of guidance documents are produced by WHO. And whilst we've got the WHO label, a lot of way back in 2007, there was Andy Oxman, who those and John Lavis and others did a review of the type of the ways in which WHO produced evidence, and they were quite scathing in this 2007 Lancet a review of that, saying that whilst WHO had some explicit processes documented for quite some time, in reality, most of the time back then, that systematic reviews and summaries of findings were actually rarely used, and that the process of developing recommendations at WHO in that time heavily relied on experts, most of which looked like this. Good old boys sitting around a table, we all know this type of scenario, and did not actually take much into account in terms of those who had to live with those recommendations, or particularly any methodological advice, and also needed to give more attention to the way in which their guidelines were disseminated and implemented, and thus whether they were evaluated to be useful. So that was quite a wake-up call to WHO, to be honest. And after that time, that was because if you think about the evidence hierarchy, which I'm sure this audience will know well, it appeared that actually most of the guidance WHO was producing was using this sort of level of expertise, not even primary studies or the work that I know many of you do in terms of synthesizing evidence further up the evidence hierarchy. So it was a big wake-up call. At that time, WHO responded, particularly in terms of their guidelines, how they developed actual guidelines. And I'll go into a little bit more about the fact that WHO produces a lot more than just guidelines, but they established what was known as the Guidelines Review Committee, which still exists today, the GRC. And that made it, and enshrined that in a handbook, sort of our Bible, really, where it's very clear as to the sort of international standards that WHO guidelines should fulfill to be trustworthy and implementable. Very standard things, but in terms of scope, target, having expert groups that are independent, impartial, balanced, and diverse, definitely should have a transparent and structured evidence approach, evidence appraisal, and make recommendations that are clear and usable. And this was actually a great success. It's continued to this day, and is considered to be one of the shining lights in terms of how WHO develops its guidance and adheres to these high standards for that guidance via this review committee, which meets once a month and has very explicit minimum standards. Importantly, if you read the handbook, it's one of the most important things about the fact that the WHO guidance is that this guideline development group in the middle here are the ones who actually make the guidance. There is definitely other contributors such as methodologists who help the guideline group, a systematic review team who have prepared the evidence. It goes into external review. Prior to that, a steering group is actually, which are WHO staff predominantly, have also given input into to prioritizing the guideline, and observers are sometimes also called upon to be part of the process. All of these, except with the exclusion of observers who have no can't participate in actually the development of any of this, of the guideline, actually have quite important conflicts of interest or declarations of interest assessed to ensure that there isn't any undue influence. So it's a rigorous process. There's many steps which will again be familiar to this audience, and various levels of approval. The GRC looks at the proposal as well as the final document, and all the usual steps of going through evidence, question formulation, evidence retrieval, etc., that you know well, and including as part of the GRADE framework, explicitly considering other issues in addition to evidence, which we know is the evidence decision framework, which are particularly important in WHO guidelines such as equity, feasibility, resource use. However, this process had traditionally taken quite a long time, sometimes many months to do. So whilst rigorous, it was a fairly long process. Then came in 2017 a new Director General, the DG, as we call him, Dr. Tedros, who was the first African to hold this post. He also commenced this, what is known at WHO as transformation, the process of transformation. And one of the key parts of this transformation process of WHO was an evaluation of what we call WHO's normative function. And I'll expand a little bit more on what I mean by normative products in a minute. But the normative function report basically recommended that WHO should have fewer but more impactful products. And these products, or known as technical products, or TPs, sometimes otherwise called global public health goods, should be prioritized. There should be a prioritization process for which ones should be supported. That WHO should introduce a quality assurance process for all WHO normative products, not just the quality assurance process that goes with guideline development. And that the impact for WHO's products should really be more than just producing how many products we produce. It should be definitely a pivot in that the focus should be on the impact, and especially of the impact of our advice or guidance or products particularly in lower middle income countries. And that would also obviously then require an improvement to the way things are translated, disseminated, adapted at country level, monitored and evaluated. So it was a pretty transformative and pivotal moment to apply this, some of the lessons learned from the GRC and guideline development process to all WHO normative products. The sort of criteria that we're talking about in terms of what should be applied to all WHO normative products is that they should be evidence-based, of course, and agile. And so we need criteria about whether particular parts of the process are followed, how rigorous the methods are, in particular things such as gender, equity, and human rights are probably addressed, how they're, can we end up with a WHO house style rather than different formats, that we should have things that are user-friendly, and importantly, that they are able to be translated and used in local settings to have an impact in country. So that's the basis for what we've done since then, are these criteria for what would make an impactful product. And how that actually got operationalized is through this document called DPW 13, which stands for the General Program of Work for this 4-year period, 2019 to 2023, with these 3 key elements that WHO should be there to promote health, keep the world safe, and serve the vulnerable. And in particular, these, what is called the triple billion goals. All these documents are publicly available. You can just Google them. And that is having a billion more people receiving universal health coverage, a billion more people enjoying better health, and a billion more people being better protected from health emergencies. This was pre-COVID. And these normative products that we produce to fulfill the goals in DPW 13 and the triple billions are things like constitutional normative products, are things such as conventions and regulations and other things approved by the World Health Assembly. Most of the products, however, are things that we would refer to as technical products, scientific or technical products, and these contain norms and standards that are set for a broad range of things such as malaria, thematic areas, and they should be based on scientific evidence and from the leading technical experts. And we also, WHO's normative products also contain things that as health trend assessments that you would know well, such as the World Health Statistics, the Global Burden of Disease, mortality, maternal mortality reports. So to operationalize that, WHO needed some strategic institutional changes. And one of the main ones was the creation of what Dr. Tedros calls his baby, which is the new science division, including an office of the chief scientist. It's probably hard to believe that prior to 2019, WHO did not have a chief scientist, but we do now. Some new departments, which I'll explain how that works, and that we should prioritize the technical products that drive country, that they should be prioritized by country need and impact, not just by numbers or what WHO departments feel is important, and that we should apply this quality assurance to all normative products and standard and streamline the way we monitor and evaluate, again, with the focus on being on impact, not numbers. So the science division is now in this schema. Some departments existed before, but were not part of the, a good civil service restructured things into a particular division. But this whole new department was created, which is the Quality Assurance of Norms and Standards Department. 3 of these parts of this department already existed for many years: the WHO Library, the Office of the Publisher that publishes the journal, the Bulletin, and other things, of course, and also the governance and review structure. For instance, WHO collaborating centers come under there. But these 3 at the top here are the 3 new departments that have been created. One called Methods and Standards, which I'm part of, and 2 other new departments called Process Efficiency, which are going to help us do all these processes more efficiently, and importantly, product design and impact. So we work very closely together, in particular, these 3 departments. We also clearly, if we're trying to improve methods and standards and evidence, would be working with other departments, these 3 in particular, such as emerging technologies, prioritizing research, evidence, policy and impact, and also public health, digital technology. And we do actually work quite well across the entire science division, but in particular with those. And this department, as I said, comes under now the Chief Scientist Office, is Dr. Simya Swaminathan. John Grove is the director. Rocco Kim is the unit head of the Methods and Standards unit, and I work with pretty much a dream team of 3 other scientist methodologists. Rebecca, Christine, and Pura have all got extraordinary experience in the field as well as in methods, and we now have, fortunately, several, about 6 or 7 consultants who are working with us to implement the program. So it's a brand new team, but quite pivotal to and seen as the engine room of improving the quality of the products that WHO produces. That was all going well, and then along came, as we know, COVID. And in a way, COVID has helped to speed up some of these transformation plans, although I've got to say it has probably set back some others. And I'll just go over a few of these now to give you a flavour for how we've implemented some of these new methods and standards, particularly regarding evidence synthesis in the context of COVID and what it means for going forward. So, as you know, WHO has produced a lot of documents about COVID. This is an analysis we just did recently in looking at how many documents we felt may contain an initial pass, some sort of guidance about what people or governments or hospitals or healthcare workers or whoever should do with regard to COVID. And we produced a large number, somewhere in the vicinity of 680. That's on average 35 a month. That's one per day, every day since the start of the pandemic. So that's a lot. Well, in my view, it's a bit unfortunate that those numbers aren't decreasing, whether the need continues or not, but the numbers are still sitting around 30-ish a month. Majority of these are published by headquarters in Geneva, but other regions, these are all the other regions of WHO, are producing some guidance documents. And there has been, to be fair, some criticism by a panel, which is known as the independent panel, the IPP, actually there should be a third P in there, IPPPR, that WHO has actually produced too many guidance documents, making it hard to keep track of, etc. But I think you can't deny that a lot have been produced. And to help with this production of guidance, which should all be evidence-based, we're an evidence-based policy organisation, and thus even, or perhaps especially during a pandemic, and especially when we know where there's been issues of an infodemic that has accompanied the pandemic, that we really want to stick with science and ensure that the best available evidence does underpin all the guidance that WHO produces. So in response to that, what we did early on in the pandemic, before I arrived, but I have subsequently taken over this group, is to have a group called a rapid review group. And it was really in response to the rapid needs of the organisation. And that ranged from, in the first few months, literally, the DG has to talk about something at a press conference at 3 o'clock today. Please find out some information about it, through to briefing documents, and now much more to full either scoping reviews or evidence reviews or full systematic reviews, and moving into living guidelines. And I'll talk a little bit more about that in a few moments. We have done those reviews, at least 100 now, in all sorts of areas. These are called IMST pillars, which is the incident management system. They have it's sort of organized into different types of groupings, such as clinical management, testing, mass gatherings, etc. So we've done an array of rapid reviews for that group. Currently, there's 2.3 full-time FTEs, all very experienced evidence reviewers with PhD trained epidemiologists. We're supported by 2 absolutely fantastic librarians who are just super good at quickly coming up with sensitive and or search strategies that help us. And this group now does quite a range of things. It still can range from very simple literature reviews. For instance, the mission to Wuhan needed us to look for papers on origins of the virus in a short space of time, but they did all the assessment of that, through to doing what we most would consider to be rapid but still full systematic reviews, including the usual things of meta-analysis, summary of findings, tables, grade ratings, etc. So this service was created early and continues to be used. Even we can't really service all the needs really we have with 2.3 full-time equivalents, but it's still very needed and very popular. In terms of the type of how we changed the way we did guideline development in the pandemic, we already had prior to the pandemic some different types. We had classified different types of guidelines. Full standard guidelines was in the description I went through before, and could take between 6 months to 2 years to develop. We did actually already have guidance on how to do both what we call rapid advice guidelines and emergency interim guidelines. Rapid advice guidelines would be compressed in timeline and abbreviated in response to a public health emergency, but they still may take 1 to 3 months. But the shelf life would be expected to be only a few months because we anticipate that data might be needed to be updated. So one might be the clinical management guidance, which we expect needs to be updated frequently as more information comes to hand on particular COVID-related clinical management. Other things could be even shorter in that they are emergency interim guidelines, which means they have a very narrow scope. They have a very short expected shelf life. Sometimes they're actually based on indirect evidence, existing WHO guidelines, or even expert opinion. Other times, as in this case, they're actually based on good quality of randomized controlled trials. But they are expected to be, they're quite narrow, short shelf life, and expect to need updating on a very regular basis. So we had these guidance already. We had a lot of information about it. It's all outlined. Some of it's all outlined in the handbook. There was a whole chapter on how to do it. In 2017, after this last version of the handbook was published, there was an addition to it in response to what happened in Ebola, which explained similar things to what I've just described. So that was already in place, but we've still struggled somewhat, I must say, to try to adhere to these existing minimum standards. They're not, in my view, standards that are difficult, should be difficult to adhere to, but and they do set WHO even though apart, especially in terms of the fact that we have to produce guidelines that are geographically and gender balanced, or we use experts that are geographically and gender balanced, because we have to produce global guidelines, unlike, for instance, the CDC or NICE in the UK, who need to produce guidelines for a particular constituency, their national population. But we have some very clear minimum standards that we are seeking to try and still adhere to. So basically, the same steps occur in this abbreviated development process, but the timelines are reduced, somewhat like 6 to 8 weeks, and some you'll see in a moment that we're even quicker than that. And a way of also keeping a track of the different types of guidelines that were and guidance that's being issued was the institution of what was called the PRC, the Publications Review Committee, which had the aims of trying to ensure that despite these very compressed timelines and abbreviated processes, that we're still producing high quality, accurate and user-friendly information, and that those, and in particular that we weren't giving conflicting advice across these many different documents. As you can see, the numbers are pretty extraordinary. This committee met 3 times a week since March 2020, since January 2020. And this hasn't been updated recently, but they're still seeing just as many publications. So we're still seeing many publications every month that are being produced. We have, though, tried now in terms of feel that there are guidelines that were potentially produced in a rapid or interim first pass should now hopefully transition somewhat from being seen by the PRC and that abbreviated process to a more either emergency or standard approval process. So we've got now a subcommittee of the GRC that can do an abbreviated off-cycle expedited review of emergency guidelines, because the standard GRC would only meet once a month and has a full committee of 20 to 30 people. And they can still do that with the same rigor as the full GRC, but a 72-hour turnaround time, which is still pretty impressive given the size of some of these documents. So we're trying to transition some guidance documents, which are now should be more stable because they have more stable evidence base, to a more standard guideline development process. The other thing we've tried to implement, or we have implemented, it's not live totally yet, is working with the McMaster team. As you know, the McMaster team have produced a COVID recommendations map or repository, and we've been working with them, and they've customized this somewhat to have groupings that are more in line with our incident management, what we call pillars, so things to do with screening, diagnosis, clinical management, and have put this into a map that WHO staff can both access directly and then download. I think ultimately we would like to make this fully accessible, because all this data is publicly available anyway. But at the moment we've only made it live about a week ago, so we're just checking validation and other issues. And you can see it's quite interesting where the heat map shows you most of the recommendations. This is the number of individual recommendations. There's something like 2,830 individual recommendations contained in the map, an extraordinary number, really. The other thing that has been sped up that we had planned to do, but has been extremely useful as part of the COVID response, is moving some guidelines where it's appropriate into a living mode. As I said, some of these traditional ways of actually producing a guideline can take, we actually don't have the actual average number, because we didn't monitor it very well prior to COVID, but this is a very typical guideline production process pre-COVID, which would take about a year at least to develop, and then would only be updated every 3 years. And this famous diagram that comes from Julian Elliott in Australia, shows that over time these recommendations contained within these guidelines often get well out of date, and then you have to repeat the whole process again. Whereas a living guideline mode is more where you're actively surveilling the literature, where you expect new evidence to be coming in, and you don't let the guidelines get out of date. So you're constantly updating. You have to make some decisions about how often you will surveil the literature. Is it appropriate to do every week or month, or are there rules or algorithms that would determine whether the emerging evidence would change your recommendation? But we have got some of these guideline data down to just a matter of days. So, a tenth as long as it used to take, for instance, the remdesivir guideline, from the time the data was made available from the Solidarity trial to the actual publication. That whole entire guideline process only took 36 days. Others have been a little bit longer for various reasons, but they're generally much, much shorter, talking a month to 6 weeks rather than a year, which clearly would not be appropriate in the middle of an emergency. So I just finished with a couple of thoughts about how we made this actually happen, and what's needed to make this sort of living guideline, keeping guidelines up to date, to actually make it happen during COVID. And I think the main issue is you just need to have so many people working with you and on standby. These are all the people that have needed to be involved to make those updates of those clinical management or vaccine or therapeutics guidelines. There's a whole team at McMaster that is constantly doing the living network meta-analysis. I think about 60 people. I think there's about 30 people at the French Cochrane Centre continually surveilling the vaccine literature and updating a network meta-analysis. My rapid review team we've talked about. We have internal departments who are always on standby. For instance, the internal maternal child health team did a recent short review of the MISC-C literature. We've got many external systematic review teams who we know have specialties in, for instance, IPC or diagnostic test accuracy or prognosis, that are virtually on standby should we need them to do something very quickly. We formed the Evidence Collaborative for COVID-19, ECC19, to try and keep all these evidence experts connected over time, and that's in conjunction with GOBSAT and Cochrane and many of the other key players in this space. We've had to be in constant contact with many external methodologists who support our GDGs, which are the guideline development groups. So people who have the expertise in all the usual systematic review, grade, evidence decision-making expertise. I've got to say they've been very thin on the ground, and they've been kept extremely busy trying to support WHO and other guideline groups. We've had our internal methodology experts. We've needed a team of experts who are not conflicted with any of these trial groups, who can give independent advice. For instance, had one pharmacologist from the UK has been very great in helping us understand some of the pharmacology behind the new drugs. And we've had to set up these standing, basically these standing guideline development groups who virtually meet once a week or once every couple of weeks for a year to cover all the questions about therapeutics, clinical management, IPC, guidelines, travel, etc. We've had to keep quite close, but not too close, let me say, to remain independent with many of the groups that I just explained, evidence review teams, methodologists. We've been in close contact with many of the other key guideline developers, so we understand what each other's doing and can share evidence synthesis where possible. We have had to be in contact with, and it's important to be in contact with industry after the guidance is developed, in order that we can make sure that things like pre-qualification and equity and access issues are addressed that can fulfill the recommendations that a guideline might make. Some of the methodological things that we've that have really helped are issues about how to gather the information. We've got these fantastic librarians who have gathered together more than 250,000 citations on COVID, including preprints and trial registries. And that's really what's made rapid evidence reviews possible. If we had to go searching individual databases for all of this, it wouldn't have been possible in that time. We've had to do a lot of had close contact with the grade group and McMaster and Godguide himself in adapting some of the grade methods to deal where we're frequently dealing, nearly always in situations of very low certainty direct evidence. And this hasn't actually changed much over time, because now variants emerge and vaccines change prevalence. Again, the evidence is always catching up with the situation. So at any one time, you often still only have very low certainty direct evidence. We've had challenges in trying to word the wordings, the grade wordings, and how they are interpreted by the public. We've had challenges in terms of capturing the complexity of an all-encompassing global guideline, which is quite different to a national guideline. We've also had some new ways of eliciting values and preferences from surveys and other things that, again, the McMaster group has led to change people's values and preferences often change in a rapidly changing global scenario, for instance, with the emergence of the variants. And we've had to have some flexibility in the way we've traditionally done evidence decision assessments. There's some new work done called WHO Integrate, which takes much more into account the access equity issues that are important for global recommendations. We've piloted some increased transparency on how we prioritize which drugs, for instance, get seen when by piloting a sort of ETD light matrix, we're calling it, trying to put into the equation things like equity and access, as well as just evidence as to whether a drug or an intervention comes up when it comes up in sequence for assessment by a guideline group. We have had some criticism that we haven't used the precautionary principle as early or as often as we should. And so we've had some great work done again by an external group who's helped us think about using this as a continuum as part of an evidence-based policy rather than just its precautionary principle or evidence. But we're still working through how and when and if and should precautionary principles should be used, and we're going to have some open to external groups soon inputting into this, which I'm sure many here would be interested in. We're also thinking about how to, traditionally WHO publication policy is that once you publish something, it stays there forever for transparency reasons, but this has caused, as you can imagine, lots of issues in terms of outdated versions and how websites, etc., and IT issues to keep up-to-date versions at the forefront. Some of this is the Australian groups, it's not WHO's, but other groups have also done things like having standing panels, making sure they have people basically on standby, that they do weekly assessments of the evidence. So we're talking a level of commitment that's very labor intensive. The other things we've done is instead of just getting your traditional PDF, being able to have digitally structured guidance where you, for instance, can click here on the landing page and go directly to, in this Magic App software, the actual recommendation, and you can drop down on the evidence to decision tables. We've done things like partner with the Magic people and the BMJ to be able to co-publish both in the WHO PDF via Magic and in the BMJ, and they're very good at doing infographic type outputs that can help the general public and clinicians understand the recommendations in a graphic way. This has been quite critical in making sure that we can keep individual recommendations within a whole guideline up to date. So the clinical management guidance and the therapeutics guidance update when there are new updates to an individual recommendation. Don't wait till we've got a whole new textbook to update. And so all of these guidelines are now in living, what we would consider living mode, and be able to have digitally structured data, which is much more adaptable. And that's going to feed into what are called smart guidelines, which are really, living guidelines are just the first digital curation. And then to actually make this go down to a level of point of care use that can be adapted, there's a whole extra layer, which again is something that we're going to be able to take forward much more quickly since the pandemic than we perhaps otherwise would, and we're working with our digital counterparts. I'll just finish by saying that we do, as part of our support to WHO technical units, provide the sort of things that you would imagine in terms of, you know, reviewing externally commissioned evidence, providing advice for methodologists. We are soon going to make a big call for external experts on all sorts of things to do with methods. So I'll be sure to make sure that you see that call, because I think clearly your group will have lots to contribute here. And we are trying to facilitate the migration of many more of the recommendations, both COVID-19 and now many others, including malaria and for self-care and others, into a digital platform, and thus, where appropriate, have consolidated and living guidelines. And just I think the final thing is just, we will, for our staff, we're going to try and improve methods and standards by having access to a methods clinic. We are working potentially with CERN and others and Cochrane to think about how we might consolidate all our evidence reviews, both internally and externally commissioned, into a way that they can be searched and shared across the organisation, which doesn't currently exist as much as it should. And we will have a new major handbook update by the end of the year, where all this new quality assurance for non-guidelines are going to be, including for non-guidelines products, are going to be found. So I'm going to stop there because we've only got 15 minutes left, and open for questions. Thanks.
Great. Oh, thank you so much, Lisa. It's actually left me a bit breathless, 2,000 plus recommendations, 30 new products a month, all these committees. And you can definitely see how COVID actually kind of pushed along some of these transformation aspects, which is really interesting. And to work under so much pressure like that. I'm sure we're going to have questions, but I'll just start you off with one. I'd like to hear, there's so many areas we'd like to explore, and I do think everybody on this list would love to hear about that call for experts when the time comes. So make sure you send that along to me, because I think there's so many diverse skills we have here. But you mentioned the evidence to decision light. Can you say a little more about that? Because, one thing I've been hearing and working on some evidence to decision stuff in environmental health is that for the standard guidelines, WHO has almost gone in the opposite direction, like wanting a systematic review for equity and a systematic review for feasibility and a systematic review for every consideration that you would put in the evidence to decision table. So I'm wondering if light is a response to that.
Yeah, well, two things. It has been light. We have, especially in the clinical management and therapeutics, we felt that very structured way of going through the evidence decision framework was actually somewhat didn't encourage so much free and full discussion. So we've considered those things, but not in a very structured format. And for most things in COVID, you just didn't. There was no point in doing a systematic review. You didn't have any of the direct evidence that you needed. So, but the ETD Light, we've been using it in terms of prioritizing which guidance comes up next for consideration. Because as you can imagine, everyone is asking us what's next, to when, and clearly companies are interested in, what might be considered next and when the recommendation might be made. And whilst we're not trying to, it's not secret, the way we've made that decision has been probably less than transparent, and we've sort of discussed it in steering committees. So we have now used that evidence decision criteria to think about not just the evidence, have we got enough randomized? So ivermectin might be a good example. There was no, if you look at the evidence base, it's very poor for all the reasons you probably all know about as well. But there were clear issues about it being used probably inappropriately, about, if it was being used when it shouldn't be used, how that affected people who needed it for other diseases, their access to that. So those factors played into, and we were just trying to document that in the same way as you do when you make a guideline, but as to why we would have, why ivermectin was assessed when it was, even though, for instance, the evidence base was pretty poor. And so the plan is we will try and do that, and at the end of each guideline update, say this is the next 3 we're considering, and for where these ETD criteria lay at any one point in time, just to be more transparent.
That's great. To use it for prioritization. I hadn't thought of it that way. Really interesting. I was just the editor on the Cochrane review for ivermectin, so good example.
You'll know all about it.
Yes, unfortunately. Do we have any questions for Lisa or comments?
This is Bob Della Valle. Lisa, can you hear me?
Yes, I can.
Okay, great. Thanks, Dr. Askie, for speaking with us today. Lisa mentioned the Cochrane. I'm just wondering, because this is a Cochrane seminar, how you have worked with the Cochrane, what more the Cochrane can do. I know you have a call for experts. I'm just wondering if you could compare and contrast it with maybe other organizations like Guidelines International Network, and who's being the best player here, who could do more. How has the crisis affected all of these partnerships?
Yeah, we're in close contact with, but basically we're in close contact with everyone we can find to do evidence reviews. So Cochrane have been great. Clearly they have certain, sometimes they have more expertise in one area than another. It's really a matter of capacity. So they are part of this ECC 19 collaborative. So we try to make sure the entire collaborative knows about, what's coming up. We have these monthly calls, what we're planning, what's coming up, and reach out to them. So so Cochrane has been pivotal, but clearly not sufficient, because I mean it's just that the evidence needs have been huge. We will be having a co-sponsored with Cochrane at the end of this in October. There's going to be a meeting that's called Cochrane Convenes, and it will be thinking about lessons learned. So how Cochrane and others, what we've learned together about evidence synthesis in this pandemic and what we could do better. But yeah, I think
and we still have our WHO working group in Cochrane, and we meet with Lisa once a month. So
that's true, we do.
Just another meeting, Lisa.
Just another meeting. I see you in so many meetings. So yes, we definitely we are definitely in close contact with Cochrane and have shared information. And I've got to say that they and NICE and NIH and GIN and others have been, everyone has been very collaborative, I've got to say. I still think we could work better on sharing stuff. We still haven't shared, you know, we do serendipitously share things, but you know, sometimes our problem is sometimes reviews have to be very global. So sometimes the PICO questions, for instance, if we get them from I think long COVID was a good example. You know, there's the questions that that NICE wanted answered about long COVID were not quite the same as we wanted, because they have a very specific situation where they have a specific healthcare system, and our recommendations have to be more global or adaptable to local.
And it sounds like you might have a little more internal capacity to do systematic reviews in-house. Are you doing more in-house, or?
A little bit, but they still need to be. We still try to always commission out if they're longer than just sort of scoping or rapid at this point in time. But some departments are very good, do their own. So HIV, malaria, you know, so non-COVID things. A lot of departments are very experienced. Yeah.
Hello.
Sorry, Bob, I might have cut you off. Oh, go ahead.
Hello, hi, this is Jean. Lisa, hi from Denver. So thank you for listening, coming into my presentation at Society Clinic Trial in 2014, the preliminary data for future prospective meta-analysis. My question to you is related to safe motherhood here. Since you are talking to a group of audience from Colorado, so I was wondering how to build this partnership with the systematic review process and your program in Washington, WHO. The challenge in Colorado in terms of maternal mortality, maternal homicide, suicide, drug overdoses have been leading causes in maternal mortality in Colorado for several years. So there is a discussion on campus and in Colorado on a $2 million per year per project for 5 years, state maternal mortality health initiative from HRSA. So there's funding coming in next fiscal year. So I want to find possibility to build a partnership between local practice here with needs global context in WHO. I cannot imagine other states, other countries facing such challenging difficulties. And I think the systematic review process will help us to learn the practice and best practice and evidence in the global context. So I want to learn your thoughts on this topic. If I can follow up meetings with you and Lisa Berger. I did meet with Lena C in her office in WHO in 2010 to talking about those issues. Thank you.
Yeah, sure. I mean, big challenges, I'm sure. The maternal child health group is very active, actually. So they do regular scanning and scoping of the literature and the needs. But I think again, what I had hoped to do with this call for experts, for instance, is not just methods expertise, also what areas people have their specialty expertise. So we want to have people who we know we can call on at short notice who have particular areas of methodological expertise and where their clinical areas are of interest and experience, be able to interact much more quickly and closely. Our evidence needs are not going away. They're only going to be increasing. And I think now we're going to implement these standards across the organisation. People will be very much looking to partner with people who have evidence synthesis experience. So I'm sure we'll be in touch.
Very good. Thank you. Thank you.
And it'll be great to see this roll out across all the different areas at WHO. So it's really good. It's a lot happening. Other questions or comments for Lisa? Great. Well, I think we all have a lot of admiration for the extent of work. What did we have another one?
No, someone's giving me some advice on where to get snowshoes, so that's even better.
Oh. Yeah, that was me from Tiffany. I'm from Minnesota originally, so I know where to get.
Oh well, you'll know all about
shoes, so I know where to get. Yeah.
Okay.
Evidently, they were hard to come by in Geneva because everybody had to exercise outside, right? So
Yes, exactly.
I'm glad at least it's hard to imagine you leaving your apartment at all with the amount of work you've been doing. So I am glad that you can get out occasionally. So thank you for that update. And I know we're really happy we've recorded this so that we can disseminate it and other people will know all the great expansion that's going on at WHO. So thank you very much.
Good. Lovely to see everyone, and we'll definitely be in touch because we need your expertise. So we'll be in touch.
Great. Thanks. Bye-bye.
Thank you.
Okay. Thanks. Bye.
Thanks very much.